Hello. Can you hear me? I'm muted over here. Okay. Hello. Can you hear me? Can you hear me now? I looked over. I was like, okay, I'm muted over there. We're going to have a problem. Okay. Let me add you to the stream. Welcome, everybody. Oh, I don't want that one. I want that one. Yes. Welcome, everybody. Welcome to our Saturday morning tea, where we discuss health information, news, education, and certification tips. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my co host, yes, today's episode is sponsored by PRN's free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start, and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Okay. So I can't hear anything that's happening over on any music that I play in the room. So I'm gonna be relying on you a lot, co-host. Okay. In Clubhouse, feel free to click the link, YouTube and Facebook friends and family who've joined us. Check the video description for the link for the 5 steps to become a certified marketable medical coder. Joining me today is my wonderful co-host, Mr. Jesse, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. Good morning, Clarice. My name is Jesse. I'm the coding nurse. I have been I've been a nurse for a good number of years, and I transitioned into medical coding about 8 years ago. And in 2020, I created a company called the Coding Nurse LLC to help other people in healthcare transition away from direct care into careers in AM.
Cool. And how's that going for you? I already know the answer to that. I said, and how is that going for you? Just like anything. Good morning, Usama. I hope I'm saying your name right. Usama Khan. Good morning. Thanks for joining. Okay, well, we have a couple little things to talk about today. Uh some doozies here as usual. There was some information regarding an OIG audit. I believe it's around some HCCs and all those wonderful things. And I'll let Mr. Jesse walk us through that information.
Okay, so this information I came to know about through LinkedIn because I follow a few people who are involved in fraud, waste, and abuse on LinkedIn, and they post whenever there are audits, whenever OIG releases, any kind of finding. So this was released earlier this month, and believe it or not, is from fiscal year 2015.
Oh, wow.
So that's why people have to understand, like the government can go back 10 years. They typically don't because they don't wait that long. But, I remember in 2019, I worked for an audit company and I was auditing dates of service from 2015. So, they can go back, like I said, 10 years, but they typically don't. So this particular company, it was a small company. They only had a sample size of 200 enrollees.
Wow.
And through their audit, they found that this company, just for fiscal year 2015, was overpaid $54 million.
Oh.
And
Oh.
so they, of course, the company disagreed. And of course, they had the OIG had their recommendations, and their recommendations were, of course, to pay back the money.
Of course. Of course.
And what I think, and the reason why I wanted to talk about this in particular in relation to risk adjustment is because risk adjustment is huge now, and it gets bigger and bigger every year.
Yes.
And a lot of people want to go into risk adjustment, but a lot of people are not understanding what risk adjustment is and how you really validate codes. I have done adjustment for almost the entire time I was a coder. I started out in risk adjustment. And where I worked, thank God, they really were by the book.
Good.
You had to validate everything. Everything had to be substantiated by, most people they use meat, some people use tamper, but you have to validate every code. And what I'm finding now with HCCs, and a lot of these companies are getting caught up because they're relying on a lot of this AI, this artificial intelligence, this NLP, machine learning, where they just abstract codes, and it doesn't mean anything if it has no support. It doesn't mean anything if it's not from a CMS approved encounter, if it's not validated by an approved CMS provider. So those are the things that have to go into valid code. And some of these codes, of course, um, their their independent contractor, the CMS independent contractor, had determined that that this company validated higher than were substantiated HCCs, because the higher the um, or the more severe the HCC, the higher the risk adjustment factor, and the more payment you receive. Now, what's interesting is they over coded 20 HCCs, but they also underreported 21. So there were, it was, so I don't know. So it seems to me that they need to have um, definitely some more training. They definitely need to have some clear policy, because if you're underreporting as much as you're overreporting, then there's indication that there's a serious, discrepancy your policy and how people are approaching these reviews.
Yes. So was this company contracted with CMS, or were they?
Yeah, they were a Medicare Part C provider.
Okay.
Medicare managed provider.
So they were a health plan.
Yes.
Okay. Okay. Wow. Yeah, I'm like you. So it appears that some serious training actually needs to occur for these folks. Wow. Let me ask you a question. So you mentioned the meat versus the tamper. Is one of them better than the other, or what are your thoughts on those?
See, I come well. I where I was trained. I've always was trained on meat.
I was. That's what my understanding was too. So when you threw tamper, I'm like, okay, wait a minute, hold up. There's new teas being spilled today.
The point, because if you can show that a condition has been monitored, evaluated, assessed, or treated, then you're home free.
Right.
And you pretty much either can or can't. Like, I don't find that meat is hard to use at all. I think that if you apply it, it's very, very straightforward.
Right. Okay. So are people going away from meat and going into tamper, or they're it just I guess depends on the
People are relying too much on this machine learning,
okay.
and they're moving away from both. To be quite honest,
Really? Because of the AI and having them
because they think that it's more accurate. But in my opinion, AI creates more work, at least in its current um, it creates more work because it does a linear search, just like Google. If you put in basket, all kinds of baskets are going to come up, but you're not looking for all kinds of baskets.
right.
So like diabetes will come up, but you have to look further, because that diabetes could be under family history. You can't do anything with that. That diabetes could be on um, on an X-ray or on a CT or somewhere other than a face-to-face approved encounter. You can't use it. Or it could be in a past medical history.
Right.
And some people, there's not enough, a lot of people don't have clear policies anymore where I'm finding, even where I work, like, because there was a time with HCC in particular, they had a list of conditions that you could abstract even if it was on a past medical history.
Mm-hmm.
And like the chronic condition, because most people, COPD doesn't go away.
Correct.
Most people, coronary artery disease doesn't go away with angina. So, unless you have like aglacia, but even where I work now, we don't have an official list of HCCs that we abstract from medical history.
Mm.
So people are just abandoning the tried and true methods that have worked.
And I wonder why.
Well, because it's easier.
Oh, I'm sure that was that was a dig, but
Because there's no pushback anymore. Like nobody tells these, because the people who are pushing this have no clue. They're not coders. They don't know about tamper. They think they know, but they don't. And you have to have someone who represents coding to say, no, that's not how it's done. And yes, this is technology that we may be able to use to help us identify codes, but you cannot rely on it exclusively. Codes still have to be validated and supported in order for us to get credit for.
Right. And like you said, using AI and those types of mechanisms creates more work, and it creates more work on the back end. So from that perspective, I always tell folks who are afraid of the technology that it's going to take over our jobs and our positions. No, somebody still needs to put some human eyeballs on some things. And in this case, it'll be on that back end, maybe not necessarily that front end, but on that back end to validate the information that was quote unquote coded by an AI system. Or so we're not going away. We're not going away. We'll be here for a while. Hi, Kim. I see you joined the stage. You said you had a question?
Wanted to add to conversation.
Sure.
Completely, totally agree with everything that's been said. These natural language processes have really taken over, and in auditing, we're finding that we're doing almost the coding all over again because the coders are such under so much pressure to make production, and they're using that natural language process to just basically capture a code without even like you say, using your meat. If you use that meat acronym, you cannot almost go wrong.
Mm-hmm.
Right. And I remember there's several clients that I've worked for in the past where they say if you just bring, and we had this conversation on my current job because we are revamping the guidelines.
Mm-hmm.
Where if you just bring the information, if the information is brought down into the assessment portion of a chart,
Mm-hmm.
and in some places I've worked where the clients are more conservative and they're like, no matter where the code is, we need some substantiation. And then in other places, they're like, it brings it down in active voice when you drop down into the assessment. And I just have a problem with that because it does. It's something that now with electronics and I'm losing my thought here, but with the system, a provider goes in, they bring everything from a previous data service over onto the current data service, and they sometimes do not go in and uncheck and check what they need to. And so I was just wanting to ask the question here about the assessment and plan component of a record. If information is brought down there, should it be captured immediately from there without any meat or tamper or any substantiation?
Not from an HCC perspective. I don't believe that would fly.
This is HCC I'm talking about. These are
yeah.
adjustment clients that I'm speaking of.
Because you have, like you said, you have to validate. There has to be some documentation to support that. That used to drive me crazy. Coding from a provider's perspective when they would have um I don't the automatic carryover of the problem list. Usually it's, well, sometimes it's a problem list. And not only will the problem list show up in, the history portion of the documentation, but then it would also show up in the assessment. And in auditing those records, probably 9 times out of 10 there would be diagnosis that there was nothing mentioned in that current encounter about that diagnosis. And their thing was, oh, well, we just copied it over, we know the patient has it, and that's fine, but you didn't address it, so you don't get credit for that in this particular encounter. Yes, the patient may have that diagnosis, I'm sure that patient has that diagnosis, but because each encounter stands alone and you didn't address it in that encounter, it doesn't count for you.
I agree. Oh, go ahead. I'm sorry.
No, go ahead.
And Kim, that's becoming more and more of a problem because there used to be a time whenever anything was in the assessment and plan, there was also some information about it.
Mhm.
If if they documented type 2 diabetes with chronic kidney disease, they would say in the plan, followed by the nephrology, or have nephrology appointment coming up. So that is enough because that's it's being monitored and it's being treated by this nephrologist.
Correct.
So, but I'm finding, more to your point, Kim, that it's just diseases or conditions are just showing up with nothing, and whether it's in the assessment or not, if there is no, like Clarice said, if there is no meat during that encounter, you can't code it.
I completely agree. And just, what I try to teach coders and let them know that when the provider is getting paid, he's getting paid fee for service. So therefore, he's only going to capture one diagnosis code to go ahead and submit that claim on, or his office. But we need that deeper dive into making sure we're capturing all the correct chronic conditions, and then making sure that if you can't go wrong if you make sure that there's substantiation for each one. But then when you work for a client that says, that is active voice of the provider, therefore you capture it, and that's almost like a sign that he is assessing it. I almost I can't argue with them if that's what the client is saying, but I just really feel like their education needs to be more, because the education is out there. They're just not using it, or they're interpreting it for their own, benefit.
I'm going to tell you. I'm sorry. Go ahead.
No. Go ahead.
I'm going to tell you why that is.
Here's the tea. Here's the tea.
There's nobody to hold these providers accountable to say you cannot do that, because where I work is the prime example, and I'm sure you can have a similar experience. Because, like, I've shared, like, I work as a CDI for this startup company, and my manager keeps me out of meetings. Like, I don't meet with anybody except for her. Like, anything that comes down the pipe, she relays it to me. And I tell her all the time what should not, what should be going on, and what should not be going on. Because where I work currently, our providers, they have nurse practitioners, and I have nothing against nurse practitioners. Their documentation is horrible, and I'm flabbergasted because these are nurses before you are a nurse practitioner, so you know how to document and you know what is required for compliant documentation. And rather than hold them accountable, my supervisor tries to come up with workarounds to help them. Like, we had another discussion again, last week, where she is insistent on trying to put coding guidelines or coding in the information in provider documentation, in provider education. And I told her, I said, first of all, nowhere have you ever given providers education. Providers get education from other providers, period.
Yes.
All we do is all I have ever done as a coder, when I met with providers, I've gone over their charts and told them about their documentation. We discuss individual cases, that it is not no blanket across the board, this is what you do. No, and I told her, I said, you keep on insisting on wanting to do it, and you're going to get in trouble. If not today, it's going to happen. I said, you do it your way. I said, I'm telling you. So she's like, well, I feel comfortable. I said, as long as your name is on it, that's fine.
To your point, you're absolutely correct, because oftentimes the provider, they're interested in their own. They've heard the general and the broad sweeping information about documentation. They're really interested in their own documentation. What information can you bring to them that helps them document better, or showing them information or issues that are opportunities for them to learn about their specific documentation. That's really what they're looking for.
Exactly. So, go ahead, Ken.
No, I just wanted to say also to that, I want to expound on that I feel like a lot of the education that we're even giving our coders, we need to spend more, and I say this we because I educate and I'm incorporating it in my program, but we also need to spend more time with the coders on documentation. Um, when we're doing the education, the breaking down of the chart components, looking for this, and there's so many different EMRs out there. I get it, but we have to have a firm. To me, we just as much as we have to have a firm understanding of the guidelines, we need to understand the documentation and what it is saying, and because the more and more I audit, and I'm a lead over auditors, it is just like I say, it's really becoming ridiculous now. The things that we're finding, and it, the doc, but Jesse, you made a great point when you said that there's no accountability, there's no enforcement. So why would they take the go the right path to learn it correctly and to understand it, to implement it? When everything is so money driven and focused, and I like the quality initiatives that are put in place, and the different pay scales that they're going through with that, but again, there's workarounds. People are
Mhm.
using workarounds for this. So I can't, this conversation is just awesome because I can't stress enough what I'm coming up against and the frustrations that I'm feeling, and even my coders are feeling, because, like they said, the production parameters are there. So what do they do? And then you get one set of advice here on how to do something. Nothing is consistent, and I think we have to find ways to um, bring in that consistency, bring in an understanding of what needs to be done, and like you said, it needs to be enforced. That was it.
And I even to and Jesse, we've talked about this before. Just having a policy, and not just a policy that just sits on the shelf to say, "Oh, I have a policy and procedure." Let me add the procedure part too, and not one that just actually sits on the shelf to say, "Oh, well, we got one." No, a working policy, one that's in use, so that people are actually using that to. Kim, to your point, go through that documentation. They have a systematic way of determining what is right and what is not. And then if they have questions, if there's something that comes up that's maybe not in that policy and procedure, then they need to escalate that to their lead or manager, and then figure out what's the best course, educate everybody, and then add that new thing to that policy. So that policy and procedure is ever evolving, and it's a working document that helps everybody. If it's just something that's sitting on the shelf, nobody's using it, nobody's touching it, you're gonna continue to see this foolishness that you see on the back end, because it's a free for all. Folks are just doing what they do, and probably just let me Google this.
So true. So true.
Let me Google and see what Google says.
I don't know why people. I don't know why it's just human nature to wait until you get slapped on the wrist to realize you have to change up.
Mm.
And people just don't want to listen. Somebody's telling you you can't do this. Let's make it right now so we don't have to deal with it later on. And they just refuse.
And that's one of the reasons why when I have those types of conversations from a compliance perspective, I have some documentation. I'm not saying this just because I just want to use my breath. I may need this breath for the last breath, so I don't really want to waste it. But let me show you right here in this document where it says blah 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 blah. I just, at some point I let the document talk for me. I'm gonna tell you, I'm gonna tap you on the shoulder, ma'am, sir. This is why you have XYZ issue. This is why we have what's going on. But let me show you the reason why I'm telling you this, and oftentimes, folks will look like a deer caught in a headlights and get the big eye, but then they'll take that information and make the appropriate changes. It's crazy.
So, case in point, can I tell you this is my situation. So, when I first came, I started in December. When I first came on board in December, I created, they didn't have a query process. I created templates and all of that. I created, their policy, everything. So, as time went on, apparently the nurse practitioners were complaining because they were getting too many queries. Now, this was not told to me. This was told to the coding manager who told me. So I'm like, but people do understand that queries are generated off of um, unclear documentation that they put. So if they don't want to be queried, that means that they need to document better, and they won't be queried.
Exactly. Exactly.
So, case in point, my my math supervisor, we had a heated conversation back in, I want to say December or early January, late December, early January, because the providers, because of course, in a review of systems, that's what the patient states. So we're not allowed to code in a review of systems. Now, I think I might have shared this example before. I've never heard any patient say I have incomplete bladder emptying. That's not a phrase that a regular person would use. Now you have incomplete bladder emptying in review of systems, but then and this is a male. Now you'll say that the person has benign prostatic hyperplasia, but then you code N40.1. That's with LUTS. So if you're going to put that, you have to put the whatever condition they have.
Exactly.
So the majority of the queries have been around N40.1. So if you don't, what they told my coder manager is, well, I'm not there. I don't know how the person used the bathroom. I'm only going by what they tell me. Okay, but if you don't feel comfortable with that this is actually true, then why are you coding N40.1?
Exactly.
Did you code N40.0? And by them putting and this is what I keep telling my manager. I like to see if you have them not code at all, then you don't have to worry about it because they shouldn't be coded. Period. So she was trying to basically say that this was a useless query. She wrote to the coding clinic. And all this is unbeknownst to me. She sent a query to the coding clinic about my query in 40.1. Why did the coding clinic come back and tell her that I was right?
Oh, did you keep a copy of all that and justify it all? Oh. Oh no. I would. You should get that. You should get that. Put that in your arsenal.
But then one of the codes they were using before I came there that they made up, they were using it incorrectly according to the coding clinic.
And look at the value that you've brought to that organization, even in the small time that you're there. That's why I said you get your documentation and you put it in your arsenal because you've brought them. They've been in business however long they were in business before you got there,
right?
Using incorrect codes, providing incorrect information, etc. And then here you come to save the day. To put policies into place to help them with some parameters. And then even when they don't necessarily, well, that's a whole, we can probably talk about that for hours. When they don't believe what you say, They don't believe the information that you bring it for whatever reason. And we all know there are probably several reasons, but for whatever reason, you're validated. Then they got to come back. Oh, well, somebody else said, well, I guess somebody who they feel more comfortable hearing the information from said, like, okay. Now what if you went out and in this case, they went to the coding clinic, so there was no exchange, no fee, whatever. But what if we went to a specific consultant? Let me go outside and pay somebody else, and they're already paying you to do your job to give them the information. But then what if they go out to an external consultant? Oh, well, we need to validate that from an external consultant, and they say the exact same thing. That was money not well spent.
And speaking of money not well spent, my my supervisor, we spoke earlier this week. She was like, because they had been saying that they wanted to bring on another CDI person, and once they get their medical record situation straightened out, they probably will. So she asked me if I wanted to be part of the interview process. So because she did send me some resumes to look at, and I only like out of the six she sent me, I only like one person.
Mm-hmm.
So um, she was like, "Well, we're gonna." She said, "You can let me know if you want to be part of the process." Blah blah blah. I don't think she wants me to be part of the process, and I don't have to be part of the process. But here's what I am going to do. When they hire somebody, I'm gonna because I'm already ready for it. I'm perched. I'm waiting. I'm gonna tell her I'm not training anybody.
Oh, so that's where it is. That's part of the process you're gonna be in.
I'm gonna need to be the senior CDI.
All right.
I'm not gonna no.
Because clearly you have the information, you have the
Exactly.
you have the knowledge base to advance not only that person individually, but the organization as a whole. Know your worth. That's about knowing your worth. All about knowing your worth. I love it, especially when you spill this tea about your job. It's bananas.
So
But as a wait before we move, but as a consultant, keep calling us. Keep spending that money. I appreciate it. Okay, I'm sorry. Go ahead.
they're not gonna go for it. So she'll probably because she's the queen of the workaround. She'll
Mm.
come up with a workaround. But that's fine because guess what? Any question you have, go to her. But I'm not having that. No.
Yeah.
I've been at this far too long.
Far too long. It's crazy. I don't understand. Well, yeah, this was great. They actually have as far as the OIG report, it's like a 59-page document. So if you want a deeper dive into that, I'll make sure the link is added to the description box so you can go in and check out the information related to
The
that.
document is very well explained.
It is.
It's very thorough.
The OIG don't play. That's why you always can say, "Oh, well, let me show you what they said." This is the reason why. This is the rule. This is the rules and the guidance that they provided. They always provide all the information to assist folks who have to go back and then educate. So, yeah, I love it. I love it. Okay. Our next topic is probably near and dear to everybody's heart. As it relates to coding, Mr. Jesse was on the article search. Actually, we had it for last week, but we had a guest last week, and so we saved everything for this week. And so ran into this article from Ronnie Berlin and Logan Lutton from the Medical Economics document that talks about the top 5 coding mistakes that cause practices to lose revenue. And interesting list. Some of them we've talked about before. Yeah. But they feel like that, having this knowledge and having this understanding should hopefully, if you are in a practice that's losing money, should stop the bleed. So the first one should stop the bleed. You hear me laugh because it's funny. The first thing they said was inappropriate N M coding. um Now, they're in their article, they talked about how it's either upcoding or undercoding. They called it too aggressive or too passive. And then, well, you have some providers that will advise their coding staff to just code down the middle. Let's take the safe route and code down the middle. And unfortunately, that's not necessarily correct. That's not correct coding either. If you're just coding down the middle, again, your coding should um, demonstrate the actual services that were provided in those particular encounters. So, yeah, uh, overcoding has always shown its place, and then folks always talk about, well, undercoding. Will they, you know, we don't have to worry about the undercoding. No, it has to be correct coding. That's what they're looking for. Correct coding, not over, not under, not playing the fence. They want your they want it correct. And unfortunately, you mentioned this today, and I believe Glenn mentioned it last week. There are lots of organizations that require their physicians to do the coding as far as CPT coding and evaluation and management coding. Now, coders or physicians doing ICD-10 coding, that one is crazy I don't understand that one, but that's a whole other animal. Unless they're in a niche um specialty that only has so many codes, then maybe I can get on board with that. Um, but if you're, general practice, you are in a specialty where you may see all kinds of stuff. That is a whole mess waiting to happen. But for evaluation and management services, it is important that the providers understand what is necessary as it relates to the documentation for these guidelines. And while the new guidelines that came out for office and other outpatient services in 2021 kind of lend itself more favorable to providers, they still need to understand what that documentation looks like, and making sure that they're documenting appropriately. I know for some of the clients that I have, particularly in the behavioral health space, everybody's shying away from that time because that time gonna get you. It could potentially get you. And so they're relying primarily on the medical decision making, which is that's what everybody is paying the doctor for, their medical decision making on what's happening with that patient, on what that patient is presenting with. So um yeah, I haven't seen any there haven't been any new audits yet to see how all of this working. I think we'll probably be a couple years out before we see some really good data around that. Individually, practices are, doing their own kind of monitoring and adjusting and even hiring external folks like myself to audit. But there isn't like a national OIG, something on to that scale or to that level that kind of and I think the reason why is because it's ever evolving, because eventually all evaluation and management services are going to have a new component, and they're going to kind of shy away from the three key components and focus on time and medical decision making, which I think is one of the reasons why everybody is up in arms when you talk about shared and split visits. But that's another conversation because they're straddling the fence there. We're in 2022. They are preparing for the changes on inpatient in 2023. And so they're writing the guidance now for that. However, since we are not bound to that guidance, they're allowed to still use 95 and 97 guidelines and the three key components. It makes things a little confusing. I'm thinking, and I'm hopefully they won't be auditing any 2022 records from an inpatient perspective, particularly if there's a shared or split visit, because it will be a mess, a whole mess.
I have always found the three key components for E&M to be very, very subjective. And it's not easy. It's really not easy to level because what one person sees as a body system, somebody else might not.
Mm-hmm. Well, one thing that I have always preached when there was 3 key components, and I still do to this day for those that are still bound by 95 and 97, is medical decision making should always be part, because you can easily, especially in this EMR world, you can click everything under the sun and get a high level visit, period, without having any real justification, any assessment, any plan to validate that. So I always tell my providers, yeah, you meet the level on paper for this code, but you don't have any medical decision making. So what is, and you have to remind them the overarching criteria is medical necessity. So why are you doing a full body exam for a person that is showing up with a cold? Why are you doing a full body exam for a person that may be showing up with something specific like arm pain? What is the medical necessity there?
Right.
And so, I always, even years ago, even before all of this, make sure that medical decision making, particularly in cases where they're established patients, because you can get by with all of that with an established patient. With the new patient, all 3 key components are part of the selection of your code. With an established patient, you can use 2 of the 3. And so I tell them, make sure medical decision making is one of those 2 that you're using to justify. And, I got a lot of pushback from that. Well, no, Clarice, that's not what it says. Ma'am and sir. It says you need to use 2 of the 3. It also says that it needs to be medically necessary. What, to me, medically necessary documentation is what you have to support why you're doing what you're doing in that encounter. And that is the assessment. These are the diagnosis, or these are the things that it's that physician's medical thought process. It's that physician's, okay, well, I see this. I think we need to do this. We need to do that. That is what justifies why you're doing what you're doing. And so I would always tell them that. And invite coders to and or auditors to get on board with that. Get on board.
But it's not taught like that in these programs.
In mine.
I'm telling you, like that the college where I tutored for like a year and a half, it's just
like I spend 2 different I have like 2 different sessions. So I do an E&M for the exam, or for the classroom, or for, just looking at that book. And then we do an E&M for the real world and what you may see and that documentation and how to justify. So I do it both, because for me, I feel like it's a disservice if you're walking out and you're thinking, oh, I can call E&M because I already know this, and this. No. You got to go through those components and those pieces. Now it's going to be a little different. And now I'm focusing primarily on the 2021 guidance, particularly for providers, and in the outpatient setting. So, but you still have to understand, because it's still piecemeal. I mean, it's similar to the 3 key components. It's just one component broken down into 3 different places, and so you still have to understand the information and the levels that are appropriate.
I have a lot of people like who reach out. Everybody wants to be an auditor, which is fine, but I don't think they. But most of them, when we have a conversation, they have no idea what being an auditor means,
Right?
And all that you have to know,
right,
to be an auditor. Like, auditing is something that you really should have some experience first.
You should, because it's not only are you looking at the documentation, but you also are trying to factor in the thought process of the person who coded it initially. So it's kind of twofold, and then trying to marry the 2, like, well, why would they do? And then figuring out, oh, I see why they may have, but then crafting your discussion on why they should or should not have, and then getting them the information and education that they need from the information. So yeah, it's a whole thing. It's a whole thing. So the other thing they had in this article, number 2 was missing E&M codes. Um, and it says oftentimes this is a result of incomplete charting. Again, documentation. Typically due to provider distractions. Charge without follow-up typically result in the claim being sent late or unbilled. Number 3 is inaccurate capturing of patient status. Wow. um yeah. The one they mentioned, and well, I guess it kind of gets interesting because they mentioned new versus established patient. And I always be like, well, it's real. They say 3 years, if they're brand new and never received services, and then you have the 3-year cutoff. I think where it gets real tricky is you have these organizations that are multifaceted, that have multiple specialties and all of those things. And it's like, so how do you determine? But there's a I know in the CPT book, there's an actual what is it called? A flow chart, or diagnosis diagram, where you can, yes or no, is this what's going on, has the patient been here before, yes or no? If yes, it has the patient, or is this provider um uh part of XYZ specialty, yes or no? If this provider part of XYZ subspecialty. So it walks you through to determine whether or not that patient is new or established. Hopefully, uh yeah, I don't I that one what's your thoughts on that?
I'm sorry.
Go ahead, Kim. Go.
No, my thoughts on that one is that it really shouldn't be a big problem, because the time that the provider spends with a new patient is going to be different than that of an established patient, unless that established patient just has so many chronic conditions and so many,
Or a new problem.
conditions.
So or a new
that's
problem.
kind of almost like a check and balances based on the time to kind of give you an indicator whether it's a new or established patient. There's certain things that a provider is supposed to be doing with a new patient as opposed to uh, an established patient. So I don't understand why that would be such a large component of why, practices are. It really kind of incorporates into another reason why, which is the documentation, which is what we've been talking about. That why practices aren't being successful or losing money. So I can't see that one being a major problem.
Can I, Kim? I think you're exactly right, but I'm gonna tell you what that is, because that same situation happened to me. I was going to this clinic because I have I've had asthma all my life, and it's very well managed with my medication. I went to a provider about a year and a half prior to me getting, because I paid cash. So when I had a job and I had insurance, I called to get another appointment. They told me that I hadn't been seen in over a year, so I have to come back as a new patient. I'm like, no. As long as you haven't been seen within 3 years,
Right.
If you've been seen within 3 years, you're considered an established patient.
Right.
So they swore me up and down. They refused to give me an appointment. So, but had I gone in, all they would have done was bill my insurance as a new patient, and they would have gotten that extra money. So, but if they were ever get audited, then they're like, well, no, he's not a new patient. He's an established patient. So that's how that works, because they get greedy.
Right. Right.
Yeah, and again, when you said about the enforcement of the rules, the policies, procedures, that's that's where all of this is. This is where all of this is stemming from. When we talk about, they changed you know, when they implemented the quality of indicators and things of that nature, you thought maybe, well, okay, there's going to be a little more accountability. But again, with all the workarounds, with and no one enforcing it, then you're absolutely correct. It's we have different rules in place, different policies in place, but the same results. I
Mm,
agree.
mm. Okay. And then the next one, let's see, Miss Administrative Procedure Codes. And they talk about particularly administrative procedure codes for minor procedures, which could be significant, and mostly dealing with like administrating or the administration codes for injections is the most routine services provided in primary care or urgent care practice. But for whatever reason, there seems to be some issue around that. um, the CPT code for the injection and a separate for the actual medication or vaccination provided. CPT is real clear in the guidelines on making sure that you code them both. Um, and then if there's other treatments that are being provided, again, the opportunity or option for modifier 25 may be applicable. Again, there are guidance and rules around that. We talked about that a couple weeks ago. Just making sure that you're following that as well.
That's a major one.
Yes. Yes.
And I think overall, I would just say that just what I have noticed in the past couple of years, I've noticed that the quality of coding education has gone down. And I think that what needs to happen is I think that companies, when they hire people, they need to have a longer training period, a longer onboarding period, and do some real education. Because it's almost like you have to, because it's like people are being taught to pass an exam, they're not being taught to get a job and to start a career.
Exactly.
So you people need more help because you don't know what you don't know until you realize you don't know it. So you have to set people up for success. If someone has completed a program, we all know that when they're new and have no experience, they're going to need some support.
Exactly.
They're going to need more than just a couple of weeks, and then here's these list of codes, and go out and do 3 charts an hour.
Exactly.
Okay,
It's not. Oh, go ahead.
no, I was gonna say, but let me throw this out there to you. How can the supervisors interview and educate when they are not coders?
Well, that's the
Well,
problem.
that's a whole problem, right? Well, there's the weakest link right there.
But it is because and not of course, but they're more your management. You know what I'm saying? They took some coding classes, okay, but they probably haven't ever worked in it, gotten down with it. So when they're interviewing, they're just interviewing a potential candidate that has the certification, shows some work experience on their resume, and then they're like, okay, and but them themselves are not coders, and that's what you'll find. They're more, like I said, they've gone through your HIM programs and taken some coding classes, but they haven't done a lot of. They haven't been in the trenches.
But a smart manager would, or person of manage would surround themselves with people who have the knowledge that they may not have. And so in those cases, then they could potentially partner that new employee with a more seasoned employee who is better at their job. And maybe relax that productivity requirement for a specific amount of time while they're mentoring the new person and showing them the ropes. So providing if they're not in a position to provide the robust training that is necessary because they're not a coder, then bringing somebody in or using the talent that they have amongst the people who can and will, and that's good management. You use your resources that you have.
Agree. I have worked on I've worked a job before where we would not promote that senior great coder, knows the information, because they needed that person to knock out that productivity and get those numbers and with a great quality score. They would not promote them to or even allow them to be a trainer.
And that's crazy. That's
The
crazy.
discussion was, we can't lose them in this capacity for that.
And
So they would promote a lesser person
Ooh.
who doesn't produce as much. Maybe the quality is still, pretty decent, but that doesn't produce as much and still not even have the highest of the quality. But they will promote them over the other person.
And that's crazy, because why wouldn't you're focusing on something linear when you can go wide. You can provide multiple people with that same information and knowledge that one coder who's doing it right, getting the job done. Why not teach the team to be like that person and then go down and you go deeper versus just, oh, we just have one and rely. What if something happens to that person? Then what? All that productivity, all that information and knowledge goes straight out the door.
I totally agree. I was on the board when we were trying to hire the candidates, and this is what the conversation. And when we got a few head shakes when you pose the same thing to them. And but at the end of the day, the decision makers made the decision to go with lesser candidates. I couldn't believe it. I was in shock.
Wow.
Kim, you raised a very, very good point, because what I had decided to do when I was looking for a job, because what the scenario you described about, you have people in management who aren't coders, but they make decisions about coders. I, to this day, whenever I leave this job, I'm never, ever, ever going to work anywhere where my supervisor is not a certified coder. Because when you work in those environments, it is a nightmare, because they want to listen to everybody except the people who have experience. And I went through that with this company, Oak Street Health in Chicago. My supervisor had a PhD in life sciences, and they had gone through. They hired only you had they hired they I guess they call themselves hiring nurse coach. You had to be a nurse and you had to have a coding credential, preferably risk adjustment, because that's what they did. Mm-hmm. So they hired three of us. Well, early on, I realized that they didn't know what they were doing and they were in trouble. And I tried to tell them, because the stuff that she was telling us to do was like, it was beyond left field. So I tried to tell them, I'm like, I was the canary in the coal mine. I'm like, no, this is not right. So fast forward 3 years later, they're being investigated by the DOJ for false claims.
Right, I was going to say, didn't we just see that? Didn't we just talk about that? And every time I ride past the little Oak Street, because there's one here. Every time I ride past it, I'll be like, "Ooh, is anybody in there? Is the doors open? What's happening in here?"
Wow. And one of the things I find with it is that your coattail will show, so to speak, because as you're gonna when you're up against deadlines and things of that nature, your coders are going to see that you can't get in there, you can't get in the trenches with them and assist them. And I think you lose a sense of maybe respect. Maybe respect is not the correct term, but
that's it. That's it.
Yeah, you lose a sense of respect for that manager. You lose a sense of, if that manager cannot, because to me you have to have some knowledge base in order to implement processes to get you through these tough times, these deadlines. Just like when we've had these, I'm speaking on risk adjustment side, when we've had these back-to-back reporting seasons due to COVID. So you have to have some knowledge base on what it takes when a coder is digging into an EMR and trying to, to validate these claims and things of that nature, in order to implement the correct process to get them through this busy season, to get them through meeting these deadlines. And if you can't answer certain questions, if you have to defer those questions to other coders or senior level coders, and that holds up time, then they do lose a sense of respect for. And then, like they say in football, you lose the locker room. So you lose the coder room.
Mm.
And so that's why I feel you have to have that background to me to be able to manage successfully.
Anytime a coder has to go to anybody other than their manager for assistance, there's a problem, period. Because if your manager is who they're supposed to be, that's your resource. And that's the only person you should go to. I've only had one job where I worked with people who knew what they were doing. I had a manager, I mean, that man was amazing. It was like 33 of us on his team, and his entire team averaged 98% every month. But the reason why is because if you called him, he was like, okay, show me a screen, we're gonna go through it together. Or this is the question, okay, well, right here in the training manual, it says on page such and such is what you have to do. It wasn't no, I was sending you, emailing me a question and I'll let you know. He stopped what he was doing, or if you had to leave a message, he'd like, I'll call you back in a half an hour, I'm on the phone with somebody else. He would call back. I mean, he made sure his team, when I tell you, his team kicked butt. I mean, because that was somebody who was committed and he knew what he was talking about.
Mm-hmm.
And he was committed to building up his team. That's all. See, people get management mixed up. People think that a manager is supposed the manager's supposed to be the most selfless person on the team.
That's right.
They're supposed to build up everybody else.
That's right.
And people have gotten it confused. And when you have a bad team, it's a bad manager.
That's right. Because oftentimes, people are out for themselves and trying to advance their career versus the folks on their team. I know I worked from a compliance perspective. Oftentimes, you have compliance teams that may or may not necessarily have any coding specialist involved. And my director, actually, she knew a little bit, enough to be a little dangerous, but she had never, I mean, she didn't have any coding credentials, she had never taken a coding class. It was just, but she understood the importance of coding as it relates to compliance. She knew, if we're going to do some monitoring, we need to have, depending on what we were looking at, there's a code that would justify. She knew we needed that code in order to get those charts, in order to do the review. If there's some guidelines, some guidance related to that code and those reviews. So she knew those, but she also knew, because I had the expertise and I was the certified coder, to make sure that I was in the room. And so I would have the conversations with, our HIM folks, directors, and I would have those conversations so that, they had their speak and we had our speak. And so she understood where I was coming from and I understood where she was coming from. And then we can go back and translate to our respective um leadership. And so to make sure that everybody understood what was needed and what needed to get done. But yeah, I think you're absolutely correct, Jesse. It's really about the management being selfless, the management wanting to advance, because you got to think about advancing the person, but advancing the person advances you, which also advances the organization. I mean, it all folds into itself. And it's unfortunate that folks don't don't think that way or don't do that. It's unfortunate. And let's see, the last thing they mentioned was, and I guess this is kind of goes right in step with what we just mentioned before, inaccurate utilization of modifiers. The largest areas are the improper use of modifiers, 25 and 59. Um, and of course this leads to audits and, unfortunately, paybacks. Modifier 25 should be appended to an E&M code to report a significant but separately identifiable additional service rendered during the encounter, such as an injection. And then modifier 59 is used to identify procedures or services other than E&M services that are not normally reported together but were appropriate to render under the circumstances. And the thing that scares me the most in all of that is the coder may have done it correctly. They may have coded it correctly, But then when it gets to the biller or the billing software or whatever that may automatically append modifiers, Jesus, that's where we have problems. And so at some point, because the coder felt like, oh, I did my part, I did it right, it went on, and then either the software added it or the clearinghouse added, or somewhere down the line, these additional modifiers were added, and it's like, okay, well, what am I supposed to do from here? What am I supposed to do now? And you won't know that has occurred until all the stuff is denied, or you're getting that piece. And so again, that's the back end having to do some rework when the front end did their part. They did what they were supposed to do. And so identifying, okay, well, there's the middle part that needs that same additional information and education as it relates to modifiers. You can't just throw stuff on there just because. And they do, unfortunately.
But oh, go ahead.
I'm done.
But that goes back to education too, because I was, I I emailed you about that modifier 25,
Mm-hmm.
and until I found, because I did a little research, and when I found that document, I'm like, oh my god, nobody has ever taught it that way,
Mm-hmm.
ever. Nobody ever said you have to go and check the code to see if it has how many global days it has to make it reportable. Nobody ever taught me that.
Wow. Wow. Yeah. It's a whole thing. It's a whole thing. Um, but then folks just think, oh, well, and not to discredit, any biller, or, even some of the billing software, because they're based on the information that it's put into it. You have payers who that's what they want to see. And so you have to make sure that you understand the payer rationale for appending XYZ modifier as well. And having documentation to support that. Oh, well, we know coding it, you shouldn't add, this modifier, but the payer requests that a modifier may be appended, and you have that documentation to support it. Oh, okay,
Right.
we did it because of this. And when there's a denial that may come through, when they come through and say, oh, well, you're not supposed to, well, we know that from a coding perspective, but your documentation told us that when we have XYZ, we are to append XYZ modifier. And so you have that information to support.
Right.
Yep. Yep. So that was good. Any other thoughts on those?
What would you say?
I said that was good. Any other thoughts on those?
Yeah. I have one more question about modifier 59.
Uh-huh.
Do you think because it is overused so much, do you think that's why CMS came out with those X modifiers?
Yes.
Okay.
Yep. Excuse me. Yep. Because it's kind of splits the hairs a little thinner. Yes. So you understand specific, because it if you looked at if you go and look at the in your CPT book in the back, so where it kind of gives you the description of the modifier, there's several things that are encompassed in that. And those X things are kind of split out to incorporate those things. Yep. Yep. All right.
That's what I thought.
Yes. So we have, let's see, Kathy and Q. I hope I said that right. And Terry and Sandra, welcome to the Clubhouse. Feel free to come up into the stage, and I was about to say in the room, up into the stage. I hear Tabitha Brown in my head. Up into the stage, and if you have questions or just want to say hi, feel free to do so. If you're on Facebook and or Clubhouse, we're now entering our Q&A session. So if you have questions or comments or things that you want to make mention of, then feel free to enter the information in the chat, and we can talk about it. You'll have us for at least the next 10-15 minutes. So if you have a burning question and desire where you have our undivided attention, now will be the time. And for free. This is free. Free 99.
Quality information for free.
Free 99. Cool. All right. So what else is happening in your world? Are we progressing with our courses, sir? Are we on point? Are we
You know what? Can I tell you?
do I need to add you to my coaching? Do I need to check in with you on a weekly basis on this?
Can I tell you? I have come to a standstill because
Sir.
I'm kind of over the clientele, so I need to come up with a new clientele to market it to make it worthwhile because I'm over them.
So who
I
are
thought they
you?
were gonna. I thought my original clientele was gonna be like it would be like I'll be able to like move the courses and really make an impact, but they they don't want to listen and they're cheap, so that's a bad combination.
don't let anybody um don't let anybody keep you from following your dream because their dream isn't there. You have quality information. And maybe they are not, maybe the audience that you think is your audience is not.
Right. That's why I'm like I have to do some thinking because I have to think about who else could I market to because I mean I'm not trying to sell pig feet at the mosque, you know.
Oh God, I'm about to fall on the floor. I love it. I love it. During Ramadan. Okay, I'm sorry.
Oh, there was this like during the pandemic. Well, we're still in the pandemic, but there were people were coming up with clear labs like all over the place to do point of care testing,
Mhm.
and they were like all over the place. They had no idea about how to bill, how to code, and they didn't want to pay people, so they were like sharing information in a group, and they were. I mean, when I tell you, my inbox was lit on Facebook because they wanted all this information for free. And I'm like, no, that's not how it works. So I was thinking about coming up with a course where I would, they'd be able to, purchase it and go through it at their own pace and explain in detail, like what a rejection is versus what a denial is, because it's very different. And, which, because different payers have different billing requirements. Like, for instance, we know that Medicare requires certain modifiers, but commercial insurance don't. They
Mhm.
don't require a modifier for that same code. So it's those kind of differences that they didn't know that they were having trouble with. And I'm like, because then I got like, do I want to even be bothered with that clientele? Because it was just becoming like, I was like, I don't know. I just really would rather find another route to go or another group.
Were you trying to market to the actual providers or?
Yeah, the
Mhm.
actual providers who
Mhm.
have the clear labs, yes.
Mhm.
Gotcha, gotcha. Okay, okay, that's good to know.
Yeah, I think if there has to be a way to possibly get to them before they are in the trenches, maybe. Like the things you need to know to start your clear lab. The things you need to
Well, let me ask this question: Are they doing their own billing or are they outsourcing?
They're
both.
doing their own.
Right. Or try or having they
They're trying
auntie
to.
or somebody else to try to learn and do and what have
Yeah,
you.
that
So
that was that was the path I was going along. There's a lot of you see upstart billing companies daily seem like now, and that maybe if you could market towards these billing companies to to get educated to provide this in their repertoire,
uh-huh.
then that might be another avenue.
No, that's a thought.
That is. That is. And have them prepared so they can have the conversations when they call them to say, this is what you need to do, blah, 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 blah. And this is why I'm charging you what I'm charging you.
Because I had spoken to people they've already had to pay back money
Mm.
but you know they had to. Then they were complaining about they weren't making enough money, but they were doing, two different tests but not using a modifier. Someone said that's why you're not getting paid.
Right.
And then when I give them all the information, they're like, okay, well, I want you to do my billing. Then we have a conversation, and they're asking me, well, what's your rate? And then when I told them my rate, oh, that's too much. Okay, well, people are losing money.
Right. Like, how much money did you lose versus how much my
Exactly.
be like, how much money did you lose versus how much is my rate?
Exactly.
And how much are you continuing to lose? Let me see. My rate is a one-time rate. This bleed is going to be continuous until you stop it.
Because what they don't understand, like I've tried to explain to them, because they're all impressed by how much money they're billing. And I'm like, it's not how much you bill, it's how much
Mm.
you get to keep.
Amen.
Because you will be audited sooner or later. And it
Amen.
doesn't matter, because I had a woman, she was a nurse practitioner. She was so excited. She was like, if this keeps up for a few more months, I'll have made $1 million. But she had no record keeping.
Oh,
So I'm like,
Jesus.
okay, so what happens when they audit you? You have to pay back $400,000 or $500,000. It doesn't do you any good.
Right. And well, hopefully you save some of that million. You got a rainy day, or not even a rainy day, an audit fund. That should be part of the conversation and the education. Make sure you keep an audit fund.
I mean, they were out here doing testing with no orders.
Oh, wow.
Like, how do you do that? And these are nurses. How do you do that? You know, goodness
You
knows
don't do
that.
anything without an order from a provider. Nothing.
And then, because they wanted to argue me down, Paris. Well, according to HRSA, it says. I said no. What it says on HRSA is you can do one test without a doctor's order. That's what it says, one. And I would even do that. Just because you can do something doesn't mean that you should do it.
Amen.
And I
That
said, no,
compliance 101.
and especially when you have states that have standing orders on their website. All you have to do is to go download it and use that person's NPI number. And they give you the parameters about who you can test and what kind of test you can perform.
Mm, wow. Amazing. Yeah, that's a good idea, Kim. The billing companies.
Yeah.
And maybe just like I was introduced through our conversations even about the guidance with HRSA. Maybe, providing that information to them, adding that. I mean, oftentimes the folks in the billing industry, they stick to what they know. But here's an opportunity to advance, especially if this is something that's new and upcoming. And hopefully it'll be something that stays around. We talked about last week or the week before, it may not stay, but if it does, here's another opportunity to add to your billing toolkit when you're marketing yourself as a biller or billing company. Wow.
Definitely.
Do you find that I know a lot of people in a lot of states, do you see a lot of these kind of point of care testing clear labs in your area?
Not really, because like the most of the places do have testing. Like people go to like CVS, or like the city itself will have like these huge testing
Yeah,
locations.
we have those
But
too.
it's not. I haven't seen a lot of like independent
Yeah.
testing.
That's the same thing here. I haven't seen that it's always the hot states. They
Right.
like, oh wait, it's something out here. We gonna try it. We gonna do it too.
Like Florida, for
Florida,
example.
Texas, California, New York. You know where they are.
Exactly. Yeah.
Yeah, wow. Wow. Crazy. Cool, cool, cool. Oh well, it seems a little quiet in here today.
Yeah.
Yeah, but we could still I was in the other room. I saw you in the other room and they were talking about building your stage and I said, "Oh yes, that was I only needed that comment right there. Build your own stage."
Yeah.
So I see some stage building, even if it's just in Pennsylvania and Ohio.
There's so much information that people, and even like the point of care testing aside, there's just a lack of coding knowledge and education here across the board.
It is, and it's so sad. It breaks my heart to see, some of the things like I've the questions that I get from folks. I'm like, what? And it's like, oh, I went through a whole coding program with who? Doing what? I don't understand. I don't understand. And it just it saddens me that I don't and we've talked about this too. Folks are just out here trying to get a dollar or whatever. And oh, I've coded and I passed my test. So let me teach somebody else how to do it. And but have you worked as a coder? Do you have any experience? Do you have any I mean, where's your knowledge base? And yeah, you can be a good mentor to somebody, and maybe I'll even stretch it to a tutor to somebody. But to actually full fledged try to teach somebody to be out here in this career for real, come on now, come on, you're doing folks a
It's a
disservice,
lot.
and it's
But
scary.
I mean, but at the end of the day, I I blame AHIMA and I blame CAHIIM because something has got to change. I mean, sooner or later, I don't know what's going to happen, but there needs to be some kind. What I would love to see happen is I would love to see accreditation of these programs tied to first time pass rates. That's what I would, because that's how it is in nursing.
That's right. That's
I
right.
would love to see that because when I tell you, you want to talk about programs changing overnight.
And dropping like flies.
Yep.
Oh, Jesus. Wait, we do have a question from Facebook. Good morning, everyone. I had to speak on the billing procedures without orders. The GI office I work for does that a lot, and she has that in caps. A lot. I asked if we were running running a running a buy one get one free special. No orders, no notes, nothing. Woo, Jesus. Y'all, I auditor's dream. Right there.
Can I weigh in on that?
Yes, sir. Weigh in.
Catherine, in 2019, I worked in this. I had a contract auditor position for a health plan here in Philadelphia, and I worked in their fraud, waste, and abuse department. And in particular, I did behavioral health and I did labs. The first thing you do, or they did, when before I even looked at any lab that was tested, I always looked to see for the date of the lab, and I also checked to see when the last time they saw a provider. 9 times out of 10, these people had never even seen a provider, that same provider that year. So where did the order come from for them to be tested?
Wow.
And these were like $2,000 labs. Like one day, just in labs alone, I denied like $10,000 for that because there's no order. You can't do that.
And here they are.
Exactly.
Here they are. Hi, Sydney. You've come up to the stage. Welcome.
Hi, hello, thank you.
You're
Hi,
welcome.
Sydney.
Did you have
I have,
a question or a comment, or you just want to just say hi?
well, I'm gonna be honest. I feel like the industry as a whole needs reform,
Mhm.
um, especially when it comes to the AAPC side,
Mhm.
um, because I don't know if you guys are in the AAPC Facebook groups, but the commentary in there is atrocious. A lot of people feel a certain way as far as outsourcing goes because AAPC is allowing people in other countries to have CPCs now. If you guys have seen that,
Mhm.
and I do agree with the accreditation part when it comes to coding in these programs. I live in the Dallas, Texas area,
Mhm.
and a lot of these programs, I'm not gonna say who, but I was taking a the HIM program that is accredited from a local college here in Texas,
Mhm.
and literally they were teaching from YouTube videos. Now, don't get me wrong. Um, yeah, I love YouTube University, like I like to call it. I do feel like I do feel like there is some content that you can get from YouTube that could be helpful and all of this stuff. However, most of these schools, in my opinion, they teach uh, barely above updated information. Um, the methodology of how they teach is not current with today's job market, in my opinion. And this is why so many people give up on the industry, or when they come into the workplace, um, that they're able to receive such low pay because the knowledge base isn't there, the understanding isn't there, and then the mentorship isn't there. And that's just my wholehearted opinion. I also feel like, to go to what you were saying, Jesse, as far as orders and documentation being crazy. One of the things that I've noticed is a lot of these managers and supervisors that are put in positions, especially when they work in private practices with doctors, they will literally side with doctors on them doing the bare minimum of their documentation, just in an effort to keep their job or keep the salary that they're being paid at. And it's like the coders and the billers are having to, like, fish with no bait to submit claims. Like, it's
Mm. Breathe, breathe. Woosah, this is a safe space. Oh.
like I've seen so much changing in this industry, and I it is just mm,
Well, I appreciate you sharing that information and sharing your perspective, because we've shared some of those same sentiments.
yeah. And even with AAPC, like you can literally go in that group, in the Facebook group for AAPC, and you can see people in there saying that they have failed the CPC exam. I've seen one lady, she said this is going to be her ninth time taking this exam. And I said, that is absolutely ridiculous. Like, there is
Exactly.
a disconnect somewhere. There is a mentorship missing somewhere. I also, unfortunately, I will see a lot of people that will come to me and they have gone to some of these technical schools
Hmm.
or schools that are like promoted on TV,
Coding and
and they're
billing.
like, "Oh,
Hmm.
I had Lord, I had to save this girl from paying
Oh
$28,000
my God.
to going to a school." Because she's like, "Yeah, I just signed up for this school. I'm supposed to start in 2 weeks." And I was like, "Well, send me the information. I want to check it out." Because what she was saying, I was like, "That doesn't some sounds wrong."
Hmm.
I went to the website, y'all. This was literally in November. Tell me why this school had ICD-9
Oh.
on their website. And when I tell y'all, I almost threw my cell phone. I was just like, you know what? This is scamming at this point, because you are charging this girl $28,000, and on your website you telling people you teaching ICD-9 and ICD-10. Like, what? I said, and there was some other stuff on there, and I was just like, yo, like, I was so angry. I ain't gonna
Mm.
lie to you, because unfortunately there's not enough pre-knowledge about our industry, and all people see is medical billing and coding, medical billing and coding. They at
Hmm.
home, in between commercials for Judge Mathis is some
That's
random
right.
school
Yeah.
talking about
Here goes some
certified
tea.
marketable billing and coders, and all of these people go to these random technical schools and they don't know any better. Like,
And they don't even know
while
what
it
to
might have been a
ask.
promising career,
Exactly.
when people reach out to me, I'm like, well, do you know you can, instead of doing that, you probably could go to school and get your RHIT,
Hmm.
or you can do this, and they're like, I didn't know nothing. They have no clue about any of that. All they see is the marketing ads about going to school for billing and coding, and the school is 36,000, and they got to take out all of these loans. But when I see, they literally said we're teaching ICD-9
Oh
and
my
ICD-10.
God.
I said, you know what? This got to stop.
Oh my God. And it's unfortunate. You know, the little people who's doing it right, we don't have those kind of marketing budgets to be on TV between Judge Mathis and the next Judge show and Steve Harvey. We don't have them kind of budgets. Woo.
This is going to piggyback exactly what you were saying. One of the women who has a clear lab had contacted me about billing. Now she has a school, and in her school she has a billing and coding program, and she was very proud of telling me that she has a school that has a billing and coding program. She's well, I just haven't taken the program yet. So I'm like, well, who is your program accredited through? I'm expecting her to say AAPC or HEMA. She mentioned some group I never even heard of, some organization never even heard of. So I'm like, okay. To myself, I'm like, that's a scam. So I didn't say anything else. So I'm like, I already know what it is. Fast forward a couple of weeks later, somebody in this group messaged me and asked me, or under a comment, they wanted to learn building and coding. What program did I recommend? So here she goes. She gonna go right in. Oh, I have a program. DM me. So me being me, I ain't want to call her out.
I love it because I know you did.
Any program, but I will tell you this: make sure that any program you take will lead to a credit, will lead to a certification through either a HEMA or AAPC, or leave it alone.
Shut all that down.
Exactly.
I remember, Lord, this was years ago, and I was I taught at a local college here in Ohio, and they are a HEMA uh, credential accredited. Accredited is the right word. And it's a RHIT program. And so, the coding knowledge is very broad, and it's not necessarily enough for certification. Um which I was fine with, and I was teaching some coding classes, and then I was even teaching medical terminology, and I was like, oh well, I'm out here, let me just keep teaching, and they were doing things online, so it was an opportunity. This was years ago, so it was an opportunity for me to understand what that looks like, and the programs and systems that they had in play. So then I get a call from an organization that's similar to one of those coding and billing you see on TV in the middle of the day, asking me, one, would I sit on their advisory board? And I get those all the time. Could you sit on our advisory board? Could you sit on our advisory board? And I'm like, oh no, let me see. I've never even heard of you. I don't know what you do. I've seen maybe one of your commercials, but let's try this out. So ultimately it was, our person is leaving and we need somebody like right now they've already gotten these people signed up who's gotten loans, so they've been paid, and now they don't have any courses or anything to offer them. And of course, they don't want to come out of pocket and refund all of this money, which they should have. I said, me being you know me. Oh, well, let me see how I can help. Try to help. When I tell you that there were 3 people in that classroom that could not read, um, I how can you code if you can't read? I mean,
Right.
for real, could not. I mean, not even read medical terminology. Read basic English. Let's go there. And so the one lady was in a dual program where she was in a GED program at night. Ma'am and sir, I said I can't teach her coding. So when all her stuff was coming back uh with F's, I was like, ma'am, they were like, well, what can you do to try to get her to a level? If she can't read, I can't help her. And I'm not here to teach reading. I'm here to teach coding. And so you all need to, and so right then and there, I saw the machine was just about the money. We don't care who you are. You could have been a person just walking down the street. Hey, you need something, you need a career, you need to do something. Come on over here. I'm like, oh my God, why would you do that? And I was like, let me, y'all, I will finish this session out, but I can't do this. My spirit would not allow me to play this game with y'all and getting people in here thinking, and I mean, they were proud to be there, proud to learn. They were, oh, we so glad you here, and the students. And so I'm like, okay, but then, fast forward to these other three who couldn't read, even though they were happy to be there too, and they were nodding and felt like they were learning something too. But how you gonna take a certification exam if you can't read? How you gonna answer any questions or do anything related to coding if you can't read? And why would you be marketing? This person couldn't read when you had them sign that loan paper for the $28,000 that it was gonna cost them to go down the drain. So fast forward, they don't have a credential, they don't have education, they don't have a knowledge base, they don't have anything but a student loan that they have to pay back. That's horrible. Absolutely horrible.
And even makes the industry look bad because when they quote unquote graduate, they can't get a job, or if they do, it's paying them, the person that hires them pays them $14 an hour. You know what I'm saying? And they were thinking that they were going to come out of school making a lot of money. This one lady reached out to me in December. She's supposed to graduate from, I ain't gonna say school because y'all know it. And I asked her a question, and I was like, "You graduate in 2 months and you don't know that?" And she was like, "Well, no, I'm thinking to myself, this gotta stop.
It has to stop.
This is my phrase. This gotta stop. Like, it has to stop somewhere. It has to stop somewhere." And the crazy thing, another thing too that I've noticed is that I don't know where this came from, but people are trying to get all of these credentials, like, infinity stones for the Avengers. Why are y'all doing this? Okay, you only been coded 1 year. You barely passed your CPC. Now you're trying to get the CPMA. You're trying to get the CP. You're trying to do way too much. Like, I don't know why that has become such a thing where people feel like they gotta have 6 credentials on their resume and only been in the industry for 6 months. It's weird. I don't know.
and that dilutes the credential, because once upon a time credentials did matter. Credentials should have mattered, because that the level of information, education, and what that certification exam stood for, but on either side, AAPC and AHEM, I'm speaking to both, stood for something. And when you dilute it, and when you allow, I think the worst thing, in my opinion, for AAPC was to remove the CPC as a standard exam that people had to take before they can get any of the additional certification exams. I think that was the worst thing they could have ever done.
You know why they did that, right?
Tell them, y'all.
This is what I believe. I believe that they did that because they're passing rates.
The passing rates. People could not pay. And that, again, that was that, to like Jesse likes to talk about, the gatekeeper. That was the gatekeeper. That was the weed the folks out. So you couldn't get, now billing aside, because that's totally different, but anything related to any coding credential, the CPC exam, you had to pass that CPC exam before you can go to any specialty. And I think removing that has just made this run them up. Just run them up. And I would feel some kind of way if I received a resume from somebody who only had 6 months in and had 8 coding credentials. Ma'am and sir, what is this foolishness?
These doctors don't care until it starts to affect their revenue.
Oh, until their business about to close and they about to look at jail time and fines and false claims and all of that. And that's unfortunate, because then you do our profession a disservice. And then you have these providers, because they talk amongst themselves, oh, well, why we need coders, or why we need this, we should be able to do that, we should be, and it makes it worse. And so then they have a distrust for the profession, when really we're here to help you. If you know what you're doing, we're here to help you stay in business and do what you're doing for the patients. It's
I'm
let me
glad
get off
you
my
mentioned it
soapbox.
because I really feel like at one point in time, being a medical coder, um, it carried a certain weight to it. Um, I don't feel like coders as a whole have the same level of respect that they used to.
Mm.
And I also feel like because outsourcing has been made available through AAPC, because at first, that was just for us. Then they moved it and they allowed people, I believe, in India to be able to get CPCs.
Mm-hmm.
And now people in Egypt, AAPC has opened it up to Egypt. So
Oh, yep. And Dubai and all of those. Yeah. Yeah.
So they're and here is the part that makes no sense to me. Why are you doing that? There is a language barrier.
But see, so one part of me understands that the why. The why, well, what I would like to believe is the good why. And the good why is that their healthcare systems are now becoming what ours was. And so they are in some countries, and in some countries they have private insurance, and they are getting to the point where they're billing, they're having claims process, they're putting all of those components together. So I understand the training of um people in India, or people in I know Dubai is, I just read an article about what's happening there, and even in Egypt, training their people, having folks to be there to do that. The problem is that we have organizations here in the US who's looking for a cheap way to get services done. And so they know, unfortunately, they may, the scale, the pay is way lower than what's happening here. And so they're reaching out and saying, okay, well, um we'll contract with XYZ company in India to do our services. And yeah, you may get a turnaround, but you're not necessarily getting a quality um product. And the biggest piece from a compliance perspective for me is a whole HIPAA thing. That's a whole other conversation. Like, wait a minute, who's doing this, and how is this working? There is no international HIPAA law. There's no international stuff to protect patients' information as it goes across the ocean. So that part is what burns me. But then you also have, it's all about the money. It's all about the money.
Here's the thing: when it comes to a documentation perspective, though, some things that translate for us translate differently. So
Exactly.
they coding something completely wrong based upon understanding of their language there. And I've seen that. You know what I'm saying?
Mm-hmm.
There was a doctor went to outsource. Again, you've seen coders in India with AAPC credentials, and he started getting denial. And it took us a while to realize, like, oh, because for us in America, this means this, for this body part, he's doing this, but over there, that's something different. And that's a whole reason why, like, that makes no sense from a documentation perspective. But then too, when you have doctors that are outsourcing, and they're paying lower salaries, right? Because um, the average salary in India, I think, is like $500 a month.
Mm.
So you're paying lower salaries, but then when you want to bring your business back in house because of loss of revenue, things of that nature. Now you only want to pay coders over here $12 to $16 an hour. I seen a job on Indeed somebody sent me. They wanted a CPC full time and they only wanted to pay them $16 an hour.
The hell? Oh God.
I'm not kidding y'all. And then on top of that, because AAPC has allowed them to get CPCs, if y'all are on LinkedIn, they are spamming people left and right because they're looking for jobs. Because here's the thing,
Wow.
they know what CPCs get paid in America. You get what I'm saying? So
Mm-hmm.
for them, having a CPC credential through AAPC is a come up for them.
Exactly.
It's better for them to live there and then be offered, maybe a little bit more than what they're used to making. So they're like all in LinkedIn everywhere. I get messages all day long. I'm like, oh, I have mercy. Like it's because they're looking for jobs because now they are taking the fee at an astronomical rate.
Wow.
In 2016, I worked for an overline, and they were really, really good in terms of training. And what happens is, you know how it is. Once your accuracy is at a consistently decent rate, they let you do overreads,
Mm-hmm.
where you just audit other, like the first review, you do a second review. Okay, so normally when I would do overreads, maybe I would have to change out of maybe four charts, maybe one code, and that's a maybe, because that's how good everybody was at the same level,
Mm-hmm.
because they were really good with their training. I started noticing that every chart that I did, I had to change like two or three codes. I'm like, the first thing I thought was, oh my God, this person is going to end up on a performance plan because they're terrible. So I'm talking to my supervisor, and I'm, selling it to her. So she was like, oh, well, there's a reason. So she didn't tell me until after, but she was getting another job. So after she got another job, she told me, she was like, oh, they've outsourced the first reviews to the Philippines. The trainer who trained me, our group as a new hire, they sent her to the Philippines to train nurses. Because for years, that's where the United States goes when they want foreign nurses to go to the Philippines, because supposedly the Philippines nursing education is on par to the American nursing education.
Mm-hmm.
So they trained them to be coders. Well, they didn't do a very good job. So also, I found out that they were paying them $4 an hour, $3 to $4 an hour. So from a company standpoint, if you have to, if you're going to have a second review done by somebody who knows what they're doing and they want to catch all the mistakes anyway, look at how much money you saved as opposed to paying two people $36 an hour.
Right.
Wow.
And
Wow.
that's why I said, like, unfortunately, I'm seeing more and more people saying that they are moving away from coding for this very same reason, honestly.
Mm-hmm.
But here's the thing though, Sydney. There's still opportunity. You have to pivot because there are other opportunities aside from just being a direct coder. If you went into clinical documentation, if you went into data analytics,
That's
you
right.
can make a fortune.
That's right.
Oh, I agree.
That's right. That's right. There's so many different arenas and avenues.
Too, how many how many formal education platforms are teaching you this?
Oh, probably not that many.
Mm-hmm.
And here's the thing: the community colleges that teach the RHIT program, a lot of those professors, they probably started coding before credentials were even in place because AAPC's only been around for about 20 years. So they probably got in because they got a job, they were trained, and they've been there forever, and now they teach the coding classes at the KHIM accredited schools. However, some of them are in only one section of the industry. They probably themselves have never tapped into doing CDI and auditing and stuff. You get what I'm saying? So they can't even teach that what they don't know themselves. You know what I'm saying? Because I know from experience, I've talked to some of them.
But a lot of them don't even keep up. They haven't done any. A lot of them have been directors of these programs for 10 years. They don't keep up on coding guideline changes. I mean, it's just whatever changes come up in the book or in that training material that comes out from a HEMA is what they do.
And just like we talked about management, a good manager would make sure they have the people with the knowledge base and the skills in their programs to teach their students. Even if they personally didn't, they would make sure that they had that resource available to those students so that they can rest assured that that student is getting the quality education that they paid for. That's crazy. Crazy.
But you got to keep on educating. That's why
It's a
that's
lifelong,
why I said
lifelong learning.
we're out here doing the Lord's work with this group. Because I'm telling you, because where else? Because I say it all the time. And a lot of these other coding groups, these people are on some bullcrap. Like they're not really talking about what is really going on.
Mm.
It's no real substance. You spill the tea, the coffee, the milk, everything, and it's. I mean, where else can you go and have this kind of frank conversation
Right.
that can really make a difference in somebody's career? You just save people time and money.
Yes, Lord. And yeah, and to Sydney's point is really, folks don't know what to ask. They see the information, they think, "Oh, this is great." They get excited and then they sign those loan papers and it's so unfortunate. I just feel like it's predatory. That's what it is. It's predatory.
It absolutely is. The thing is, the people that they're speaking to enroll,
Look like me and
they're my
you.
brothers.
They look like us. And
That's
it's
right.
predatory. That's what it is.
That's right. Well, look, I told you last year, but when I left that college, I left in a blaze of glory because I sent a 4-page resignation letter. When I tell you, I remember everybody.
Not a 4-page letter.
Jacked them over, ran them over again. I named names because, and that's what I put in there. The sad part is, it is the bottom line is it is allowed to go on because the people that are impacted look like me. I think these are mothers. These are people who are really trying to improve their lives
That's right.
to improve the lives of them and their families. And you know that these people that you have in these programs are not qualified to teach anything, and you don't care
That's
because they
right.
don't look like you, and that's the truth.
And they don't have enough wherewithal to read the information. They think, and in some cases, they sign that $28,000 loan note, promissory note. And they may give them $1,000 a quarter. They may give them, and they're like, "Oh, I'm coming up. I gotta come up because I'm getting this additional little money on the side." But really, oh my God, you're gonna pay. You signed a promissory note for $28,000. You're gonna end up paying $60,000 before it's all said and done.
But Clarice, even when I left last year, there were a couple students that I knew were really really trying. I even contacted them. I even sent them a copy of my resignation letter. I'm like, if you know what to do with this, you could get all of your money refunded. I said,
Wow.
but I can't tell you what to do. I'm just telling you, you have enough information. If you go to the right people, because one thing's for sure, if you go to these United States Department of Education and file a complaint about some false advertisement and about a diploma mill or something not, or people not teaching and being accredited, they'll do something about it.
Right. They'll do an investigation.
Because I did that with a barber school in New York City.
Mm, mm, mm.
When you pay your money, when it comes to education in this country, there are rules and regulations. Now they might not enforce them, but if you don't let them know something ain't right, they're not going to know. There's too many of them.
There's too
When
many.
you ring that bell, they're going to answer.
That's the truth. That is a good nugget right there.
Yeah.
That's a good nugget right there. Well, on that note, we've been around for 2 hours today. Oh my God.
Yeah.
We've been here for 2 hours. It's been good.
Great talking to y'all.
It was great talking to you. Come in anytime, Sydney. Come on in. Make sure you click the little green club so you can be part of the club, and then network with folks. I followed you. Make sure you follow. And we can have additional conversation. We're here every Saturday morning at 9 a.m. Mr. Jesse, do you have any closing thoughts? I'm going out. Let me just say, I'm going out with heart pressure.
I really enjoyed it. And Sydney, it was great talking to you. We just have to, what we have to do, we just have to find out. I'm going to do some outreach. I'm going to
We are.
They need to hear this information.
They do, and to help them, we may not necessarily be, because me, I always tell folks I ain't for everybody, because my stuff is
Right.
is real strict and regimented, and you got to work. It's a working program. It's not one of them. Let me just passively provide you some information, and you think you got whatever. No, you gonna work, and you're gonna show me that you work, because my name and my reputation is on the line, and my stats are on the line, and I'm passionate about making sure you get to where you need. That's the whole point and purpose of why I do what I do. And so, yeah, so I may not be for everybody, but at least they can hear some of this tea that's being spilled.
That's right.
They can hear this tea. They can hear it. Well, again, thank you all for joining us this Saturday morning. It was great. All kinds of
Yeah.
like you said, tea, coffee. I don't even drink coffee, but probably some coffee and maybe Kahlua. Let's add some Kahlua to it. All kinds of stuff was spilled today. And if this information was valuable for you, please help us share this message with others by liking the video, sharing the video, and subscribing to the channel. And you can also check out Mr. Jesse at the Coding Nurse YouTube channel. You had anything coming up in the next week or so, or you wanted to announce? No, not yet. Okay, well, uh, if you click on the notification bell, you will be notified when he uploads a new video. So make sure you click that. You can also click the notification bell over here at the Professional Reimbursement Network as well. Last but certainly not least, as I mentioned to my Clubhouse people, and Sydney, I see that I'll click up as soon as we get off. I'll click over there. Last but certainly not least, for the Clubhouse folks, make sure you click on that green Clubhouse so you can be part of our club and get notifications of our live broadcast again on Saturday at 9 a.m. This has been a great session. I can woo-saw a little bit, even though Sydney done took me to a whole different place. But I got some. You know me, I'm always got my pen and paper, and I'm writing notes. So I got some things that were good, and so I had an education today. I got some learning. I got some gems, both from the people that are placing their comments on YouTube and Facebook, and also the people that come up to the stage and talk to us on Clubhouse. So feel free. This is a safe space. Come on in. Let us know what's happening, so that we can help each other be the best that we can possibly be. So again, thank you for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care and be safe.